Now we are going to discuss small intestine, and in small intestine first we are going to discuss briefly congenital anomalies of small intestine. Congenital anomalies: atresia and stenosis. Atresia is the absence of lumen and stenosis is narrowing of the lumen. These can be seen in any part of the small intestine. The commonest site is duodenum, followed by jejunum and then ileum. Presentation is with complete or incomplete intestinal obstruction. So the presentation is with complete or incomplete intestinal obstruction. Then another anomaly, which is duplication. Usually a small segment is affected, but rarely the entire length is duplicated. Malrotation. Normally, as midgut grows, it becomes rotated at an angle of 90. Rotation is anti-clockwise. Failure in this rotation result in abnormalities of position. An important point: failure in the rotation results in the abnormalities of the position. Now this is the photograph showing the gross appearance of congenital duplication of the bowel. This is the normal. This one is the normal. You can see this one is the normal, whereas this one is the duplicated. It was an incidental finding in an adult, and the duplicate segment has a blind end. You can see that the duplicate has got a duplicate segment has a blind end. Then Meckel's diverticulum, the white line duct which connects the lumen of the developing gut to the yolk sac, normally involutes before birth, and a ligamentous cord is left behind. Now when duct persists, it gives rise to a diverticulum situated on the anti-mesenteric border about 30 cm proximal to ileocecal valve. Now you should remember the rule of 2. This is the most common congenital anomaly of GI tract, seen in 2% of population, located 2 feet from the ileocecal valve, and it remains asymptomatic. Ectopic gastric mucosa may be present in the wall of the diverticulum, giving rise to peptic ulceration. So it may contain ectopic gastric mucosa and peptic ulceration results. Now here you can see the gross of Meckel's diverticulum. Okay. Now in this case you can see ulceration, and this is due to ectopic gastric mucosa. It can also contain ectopic pancreatic tissue which does not produce any symptom unless it forms a mass which is large enough to predispose to intussusception. Small intestinal obstruction, then we are going to discuss it briefly. Any condition which interfere with onward movement of the intestinal contents constitute intestinal obstruction. It can be complete or incomplete, acute or chronic, Complete obstruction is an emergency and it should be promptly treated, otherwise it can prove fatal. Obstruction can be mechanical, neural, or vascular. Mechanical, neural, vascular. Mechanical reasons can be internal or external. Internal, inflammatory strictures, tumors, congenital atresia or stenosis, meconium ileus, foreign bodies, presence of roundworms, or due to gallstones. External causes, peritoneal adhesions, obstructed or strangulated hernias, intersusception, volvulus, compression by the tumors. These are the external causes: peritoneal adhesions, obstructed or strangulated hernias, intersusception, volvulus, compression by the tumors. Now there is a photograph, a gross appearance. A small segment of bowel that has been trapped in the hernial sac, entire one. It is strangulated, undergoing ischemic discoloration and necrosis. Vascular causes, thromboembolism, accidental ligation of mesenteric artery, which results in infarction and gangrene. So these are the outcome of the vascular causes. They can be infarction or they can be gangrene. And causes are thromboembolism, accidental ligation of mesenteric artery during surgical procedures. Effect of obstructions, effect of intestinal obstruction. This depends on site and mode of development. Complete and acute obstruction. The bowel proximal to obstruction shows first increase in motor activity. So in the intestine proximal to the obstruction first shows increase in the motor activity and ultimately followed by obstruction. The wall of the intestine is dilated and stretched. So once the wall of the intestine is dilated and stretched, it becomes thin. Large amount of fluid accumulates and rich medium for the growth of all sort of intestinal bacteria is provided. So there is accumulation of large amount of fluid which provides rich medium for the growth of all sorts of intestinal bacteria. But once there is acute and complete obstruction, antiperistalsis sets, resulting in severe vomiting, pain, electrolyte imbalance, and shock. Now, as I discussed with you, that there is dilatation and stretching of the intestinal wall, resulting in the thinning of the wall of the intestine. With the result, it can undergo perforation and diffuse acute peritonitis can occur. This condition is fatal unless emergency surgical measures are taken. Chronic obstruction results in the dilatation of the wall of the intestine proximal to the site of the obstruction. Initially, there is dilatation of the wall of the intestine. But here, the wall is thickened due to muscle hypertrophy. The intestinal wall is thickened due to muscle hypertrophy. Stasis of intestinal contents lead to inflammatory changes in the mucosa with ulceration. Important point. Perforation may take place leading to acute peritonitis. So once there is ulceration, this can lead to perforation and acute peritonitis can result. Now, absorption from small intestine. Small intestine provides an environment for absorption of nutrients from the food. The pancreas secretes digestive enzymes which are necessary for the breakdown of macromolecules in the food. Diseases of pancreas like cystic fibrosis, chronic pancreatitis, carcinoma of the pancreas, and pancreatic surgery results in defective absorption because the function of the pancreas is disturbed. With the result, the pancreas is not performing its function, so there is impaired absorption. The liver secretes bile acids for solubilization and absorption of fats. Impaired bile secretion leads to impaired solubilization of fats, resulting in impaired absorption of fats. So absence of bile leads to impaired solubilization of fats. So absorption of fat from the intestine is impaired. With the result, there is also malabsorption of fat soluble vitamins like vitamin A, D, E, and K from the gut. Transverse intestinal mucosal folds and finger-like villi gives a vast area of absorption to the intestine. The mucosa is the site of a set of enzymes like sucrase and lactase, which are located on the brush bottom. They hydrolyze large molecules for absorption, especially complex sugars. Absence of these elements lead to impaired digestion of food and malabsorption. Loss of absorptive surface of the bowel seen after surgical resection in infarction or Crohn's disease reduces the absorptive area markedly. I repeat, loss of absorptive surface of the bowel seen after surgical resection in infarction or Crohn's disease reduces the absorptive area markedly. Now, in severe Crohn's disease, extensive mucosal edema and flattening of the mucosa reduces the surface area for absorption of nutrients. Diseases of the terminal ileum prevents absorption of vitamin B12. Now, here is the microphotograph which shows that there is mucosa of the small intestine thrown into finger-like process result in the formation of large area of absorption of the nutrients of the digested food. You can appreciate the goblet cells, and these are the finger-like process. Now this histology is very important because its significance you will find in number of diseases which we are going to discuss later on. Now the most important small intestinal cause of malabsorption in the Western world is celiac disease, whereas in the developing world countries or third world countries it is parasitic and worm infestation. Okay, now another important topic which we are going to discuss, malabsorption syndrome. Malabsorption syndrome, it consists of number of diseases which lead to this condition. That is, a number of diseases lead to malabsorption syndrome. This is characterized by suboptimal absorption of fat, vitamins, proteins, carbohydrates, electrolytes, minerals, and water. It is characterized by suboptimal absorption of fat, vitamins, proteins, carbohydrate, electrolytes, mineral, and water. Now, there are a number of diseases which are included in malabsorption syndrome, but the most common they are tropical sprue, celiac disease, Whipple's disease, and Abetalipoproteinemia. Now, clinical features of the malabsorption syndrome. What are the clinically how malabsorption syndrome presents? There is passage of abnormal, bulky, frothy, greasy, and foul-smelling stools, which are due to the malabsorption of fats and other nutrients. malabsorption of various food particles. Now I am elaborating it. Malabsorption of various food particles like fat, that is steatorrhea, which leads to weight loss, anorexia, abdominal distension, anemia, and muscle wasting. So passage of abnormal, bulky, frothy, greasy, and foul-smelling stools in malabsorption syndrome. And there is malabsorption of various food particles like fat, giving rise to steatorrhea, then leading to weight loss, anorexia, abdominal distension, anemia, and muscle wasting. Now we are coming to the entity which is responsible for malabsorption syndrome, and that is tropical sprue. It is also called environmental sprue. It is also called environmental enteropathy or tropical enteropathy disorder, which is prevalent in areas and populations with poor sanitation and hygiene. It occurs in people living or visiting the tropical regions. And those areas are Mexico, Central America, Caribbean islands, South India, parts of Sri Lanka. The exact cause is unknown. In tropical sprue, the exact cause is not known. However, enterotoxogenic E. coli is a possibility. Respond to broad spectrum antibiotic therapy, so that supports that there is it's bacterial in origin, and severe cases are associated with intestinal malabsorption of iron, vitamin B12, and folic acid. Variable intestinal changes ranging from normal to resembling those of celiac disease. Coming to celiac disease, there is partial villus atrophy and sometimes subtotal atrophy. Lamina propria has abundant lymphocytes and more eosinophils than celiac disease. As I've already told you, that bacterial etiology, that is of E. coli, is blamed, so no risk of malignancy. Very important point. No risk of malignancy in tropical sprue. Now celiac disease, this is also called celiac sprue or gluten sensitive enteropathy. This disease has a worldwide incidence of 0.6% to 1%. It is immune mediated disorder. It is triggered by the ingestion of gluten containing foods such as wheat, rye, oat, or barley in individuals who are genetically predisposed. Now, its incidence is rising in many countries where it was uncommon previously because the change in the habits of intake of food. Genetic factors are important also because familial clustering has been reported. Seen at any age, characterized by lesions present in the small intestine. Now, this disease can be seen in adults and can be seen in children. When seen in adults, this disease is seen between the ages of 30 and 60 years and twice more common in females. Some patients present with silent celiac disease, which is defined as a positive serology and villus atrophy without symptoms. So we call this, when these two things are present, that is the serological findings are positive and histology shows villus atrophy, but there are no symptoms. We call it as silent celiac disease. On the other hand, there are many cases of celiac disease which escape clinical attentions for many reasons because of atypical presentations. Then latent celiac disease, in which positive serology, serology is positive, but it is not accompanied by villus atrophy. So not accompanied by villus atrophy. We call it as latent celiac disease. Silent celiac disease, positive serology, positive histological findings, that is villus atrophy. Latent celiac disease, positive serology, not accompanied by villus atrophy. Celiac disease may be asymptomatic, but also present with chronic diarrhea, bloating, or fatigue. Most cases present with anemia due to chronic iron and vitamin malabsorptions. Dermatitis herpetiformis may be a feature in about 10% of patients. So, dermatitis herpetiformis may be the presenting feature in about 10% of the patient. When we come to children, both females and males are equally affected. May present with malabsorption, or there are atypical symptoms affecting almost any organ. The manifestations of disease begin between 6 to 24 months of age after feeding the child with gluten containing diet. The classical symptoms are irritability, abdominal distension, anorexia, chronic diarrhea, failure to thrive, weight loss, and muscle wasting. So we were discussing the classical symptoms are irritability, abdominal distension, anorexia, chronic diarrhea, failure to thrive, weight loss, or muscle wasting. And in children, both males and females are equally affected, may present with malabsorption, and manifestations are seen between 6 to 24 months of age after feeding the child with gluten containing diet. But there are non-classical symptoms which tend to occur at older age with complaints of abdominal pain, nausea, vomiting, bloating, or constipation. Now, celiac disease has got extra intestinal manifestations. Extra intestinal manifestations which are seen in celiac disease are arthritis, aphthous stomatitis, iron deficiency anemia, delayed puberty, and short stature. Now, pathogenesis, gliadin has the most of the disease producing component. Digestion of gluten takes place by luminal and brush border enzymes into amino acids and peptides. So gluten is broken down or digested by the enzymes present in the lumen and the brush borders into amino acids and peptides. There is also formation of a 33 amino acid alpha gliadin peptide that is resistant to degradation by gastric, pancreatic, and intestinal proteases. So small intestinal proteases, they cannot degrade the 33 amino acid alpha gliadin. Exposure to gliadin leads to release of ranulin, which is a protein, and that increases the permeability of the tight junctions present between the enterocytes. Okay, I think it must be clear to you that there is a protein known as zolinolene which increases the permeability of the tight junctions present between the enterocytes. And it works by engaging the chemokine receptors CXCR3, and these receptors, that is CXCR3, are overexpressed in patients with celiac disease. I'm going to show you the photograph of that. Zolinolene binds with CXCR3, resulting in the breakdown of tight junctions between the enterocytes. Now please come to the photograph. This is the gluten which is present in the diet, and this is the lumen of the intestine. It has enzymes which breaks this gluten. This is the gliadin formation, and this is the CXCR3 receptors which are overexpressed in individuals who are genetically susceptible to celiac disease. Right. Now what happens so zolinolene binds with CXCR3, resulting in the breakdown of tight junction between the enterocytes. Now, once these tight junctions are broken, this result in the increase of intestinal permeability, which allows more gliding to enter the lamina propria of the intestine. Okay, again coming back. So permeability is increased. This is the lamina propria, and more gliding is entering. Now, gliding induces enterocytes to release interleukin 50. So, gliding induces enterocytes to release interleukin 15. Interleukin 15 causes an increase in the proliferation and activation of intraepithelial lymphocytes, which are abbreviated as IEL, that is intraepithelial lymphocytes, which are CD8 positive. Okay, so gliding induces enterocytes to produce interleukin 15. Interleukin 15 in turn causes the proliferation and activation of intraepithelial lymphocytes, which are CD8 positive. Interleukin 15 also triggers intraepithelial lymphocytes to express NKG2D, which is a natural killer cell marker. So, if you go by steps, I think the things will be easier for you. First, the intestinal permeability is increased by the breaking down of the tight junctions. More glidin enters the lamina propria. Glidin induces enterocyte to release interleukin 15. Interleukin 15 causes an increase in the proliferation and activation of intraepithelial lymphocytes, which are CD8 positive, and also interleukin 15 triggers intraepithelial lymphocytes to express natural killer marker, which is NKG2D. The ligand for NKG2D is MIC-A. Now, MIC-A is expressed on the surface of the enterocyte under stress and bacterial infection. It has been mentioned in the literature that exposure of excess amount of glidin is a stress itself. Now, these enterocytes are now attacked by NKG2D expressing intraepithelial lymphocytes. So, the lymphocytes which are intraepithelial and containing NKG2D marker, which is a natural killer marker, now they attack the enterocytes, which has got a ligand known as MIC-A. Destruction of enterocyte takes place. So once there is destruction of the enterocytes is taking place, more gliadin is coming and the cycle is repeating itself, and this destruction is taken place by the release of granzyme and perforins. This is the whole written here. You can see that gliadin stimulates the enterocytes to produce interleukin 15, and this interleukin 15 triggers NKG2D on the intraepithelial lymphocytes, which are CD8 T cells. Moreover, enterocytes, they express a receptor which is MIC-A, and it acts as a ligand for NKG2D. Okay, so ultimately there is destruction of the enterocytes take place by these activated intraepithelial lymphocytes. So more and more gliadin that comes into at the site of lamina propria. Now, as this gliadin peptides, they are entering the lamina propria, tissue transglutaminase acts on it, results in the formation of deamidated gliadin. So tissue transglutaminase acts on the gliadin peptides or gliadin and resulting in the formation of deamidated gliadin. Now this deamidated gliadin is more immunogenic. So what happens? This deamidated gliadin is taken up by the antigen presenting cells, and they process it and present on the receptors which are DQ2 or DQ8. With the result, they interact with T cell receptors. These are the T cell receptors. These are the T cell receptors, and stimulate T cells to produce interferon gamma, and results in further destruction of the enterocytes. These T cells, they also stimulate B cells to produce anti-gliadin antibodies, anti-endomysium antibodies, anti-transglutaminase antibodies. I have discussed with you the whole slide. Morphological features. Biopsy is taken from the second part of the duodenum or proximal jejunum. Increased number of intraepithelial CD8 T lymphocytes. So morphological features, the three important. Intraepithelial lymphocytes increased, and they are CD8 T lymphocytes. Crypt's hyperplasia and villus atrophy. So villus atrophy with crypt hyperplasia, that results in unaltered mucosal thickening. Once there is villus atrophy, one feels that there is going to be thinning of the mucosa, but due to crypt hyperplasia, the mucosal thickening remains unaltered. This loss of mucosal and brush border surface area contributes to the malabsorption. Mucosal and brush border surface area is lost, resulting in malabsorption. Increased number of plasma cells, mast cells, and eosinophils are seen especially in the upper part of the lamina propria. Now it is very important point that interpretation of the results are by combining serological and histological features together. Now diagnosis: serological tests are performed prior to intestinal biopsy, because intestinal biopsy is an invasive procedure, so one must carry out serological tests first. The most sensitive test is the estimation of IgA antibodies against tissue transglutaminase, then anti-gliadin antibodies, then IgA anti-endomysial antibodies can also be present. And if there is deficiency of IgA, then IgG anti-tissue transglutaminase antibodies can be detected or estimated. Now this is an important point. The absence of HLA-DQ2 and HLA-DQ8 is useful for its negative predictive value. Now this word you should be very clear about it. These two alleles, they were present on the antigen presenting cells, which presented the gliadin, or which presents the deamidated, gliadin. But if they are absent, they rule out celiac disease. So they have got a negative predictive value. If they are absent, if they are not detected, it is useful to diagnose celiac disease. Biopsy answer shows increased intraepithelial lymphocytes, crypt hyperplasia, and villus atrophy. However, final confirmation is also when the patient is put on gluten-free diet. Once the patient is put on gluten-free diet, the histological changes, there is regression in those changes, either partial or complete regression. So the morphology almost comes to normal. Risk of malignancy: the commonest cancer is enteropathic associated T-cell lymphoma, which is an aggressive lymphoma of intraepithelial T lymphocytes. And then there is increased risk of small intestinal adenocarcinoma and carcinoma of the esophagus. Treatment: changes marked, as I told you, in the duodenum and jejunum, Patient put on gluten-free diet. The changes regress to gradual recovery of villus structure, which may be partial or complete. Now, there's a photograph which is showing this is the normal architecture of the intestine and small intestine. The mucosal fold are thrown into villi, whereas in this side shown by the yellow arrow that there is loss of villi and flattening of the mucosa. Loss of villi, loss of villi and flattening of the mucosa. Here you can see that there is dense population of inflammatory cells and also there is presence of mitosis. Whipple's disease, another important disease. It is a systemic bacterial disease involving intestine, central nervous system, skin, blood vessels, heart, lungs, liver, spleen, kidney and joints. It is caused by infection of Trophirema whippleI, a gram-positive non-acid fast bacteria seen in 40 to 50 years, male more common, being affected by this disease in the ratio of 10:1. Now in this disease there is triad of symptoms, and that is diarrhea, weight loss, arthralgia. This is the triad: diarrhea, weight loss and arthralgia. Symptoms occur as microorganism-laden macrophages accumulate within the small intestinal lamina propria and mesenteric lymph nodes, causing lymphatic obstruction. With the result, the malabsorption diarrhea of Whipple disease is due to impaired lymphatic drainage. So malabsorption is produced due to the loose motions. The diarrhea which is produced is due to impaired lymph drainage. Extraintestinal symptoms: arthritis, arthralgia, fever, lymphadenopathy, neurological manifestations, cardiac manifestations, pulmonary diseases, and these diseases may precede malabsorption. Focal hyperpigmentation of skin, and this disease, that is Whipple's disease, responds to antibiotic therapy. Morphological features: there is dense accumulation of distended foamy macrophages in the lamina propria of small intestine. Granules are partially digested bacteria within the lysosomes. These macrophages contain PS positive products of bacteria. Intact rod-shaped bacilli can be seen by electron microscopy. Similar macrophages are present in lymphatics, lymph nodes, joints and brain. Inflammation is absent. Now this is the micro photograph where you can see these are the foamy macrophages which contains degraded parts of bacteria, and which can be demonstrated by PAS stain, foamy macrophages containing bacteria, and other entity which leads to malabsorption syndrome besides tropical sprue, celiac disease, Whipple's disease, which we have discussed, is Abetalipoproteinemia. It is a rare autosomal recessive disease. It is due to inability to assemble triglyceride-rich lipoproteins. It is caused by mutation in microsomal triglyceride transfer protein, which is M.phil. Lipids, they accumulate intracellularly. Triglyceride accumulation takes place in the form of epithelial vacuolization, which is shown by oil red O stain, particularly after fatty meal. Abetalipoproteinemia presents in infancy with failure to thrive, diarrhea, and steatorrhea. Now there is failure to absorb fatty acids, which leads to deficiency of absorption of fat-soluble vitamins, and this results in lipid membrane defects, which can be seen by the presence of acanthocytes in the peripheral blood film. And acanthocytes, they are the RBCs which have got spikes on their membrane. Now, gentlemen, I have covered the subject briefly. If you have any question, please do write in the comment box, and inshallah I'll answer it. Thank you.